The knee region. The knee is a complex joint with 3 bones, which is the femur, tibia, and patella, 2 degrees of freedom of motion, and 3 articulating surfaces. The medial tibiofemoral, lateral tibiofemoral, and patellofemoral articulations, which are enclosed by a common joint capsule. However, not all of these ligaments lies within the capsule. So the knee can support the body weight in the erect position without the muscle activity. So an individual is able to rely on the joint's ligaments to maintain quiet standing. Although it is the largest joint in the body, the knee is among the more frequently injured joints within athletic and industrial environments. We all know that the knee joint is one of the largest and most complex joints in the body. It is constructed by the 4 bones and an extensive network of ligaments and muscles. So as what I said, the part of the knee between the end of the thigh bone is the femur, and the top of the shin bone, which is the tibia, is called the tibiofemoral joint. So the patellofemoral joint is between the end of the thigh bone, femur, and the kneecap is the patella. So one factor that places the knee at risk is the large torque it receives because of its position between 2 long lever arms, the femur and the tibia. The multiple functions of normal knees to withstand large forces, to provide great stability, and to afford large ranges of motion are achieved in a unique way. The relatively shallow joint provides for extensive motion, but the joint configuration means that the knee must rely on soft tissues structures for its primary support and stability. Let's proceed with the bones. So the 3 bones comprising the knee include the femur, tibia, and patella. Although the proximal fibula is near the joint, it is not considered part of the knee. However, it does play a role in ankle function. So it is presented in chapter 11. Because of the soft tissue surrounding the knee, it is easier to palpate the bony structures anteriorly than it is to palpate the posterior structure, which are covered by the hamstrings and the gastrocnemius muscles. It is also easiest to palpate these anterior structures with the subject sitting on the table and with the knee relaxed in 90 degrees of the flexion. For the femur, the distal femur forms the proximal end of the knee joint. The distal femur changes to expand its design in a medial lateral direction. This medial lateral distal femoral expansion is referred to as the medial and lateral condyles. These condyles are covered with articular cartilage and are connected to each other anteriorly but are separate posteriorly. On average, the medial condyle is 1.7 cm larger than the lateral condyle in adults. The anterior superior aspect of the condyle forms a groove between them in an intercondylar groove or trochlear groove. It is where the posterior patella articulates with the femur and intercondylar fossa separates the 2 condyles at their most inferior aspects, and posteriorly, it is through this fossa that cruciate ligaments transverse. The tibia. The tibia flares at its proximal ends as it meets the femur to form the distal portion of the tibiofemoral joint. The articular surfaces of the tibia are significantly smaller than those of the counterparts of the femur. But the tibia has 2 slightly concave latus or condyles corresponding to the medial and lateral femoral condyles. The patella. It begins its ossification process by the 3rd to 5th year to ultimately become the largest sesamoid bone in the body. Sesamoid bones are small bones that lie within a tendon to protect the small bones that lie within a tendon, to protect the tendon and change the tendon's angle of pull. Since the continuation of the tendon connects two bones, the patella and the tibia, this distal structure between the patella and tibia is the patellar ligament. Let's proceed with the joints. The knee complex contains two joints, which is the tibiofemoral joint and the patellofemoral joint, surrounded by one capsule. Tibiofemoral, as the largest joint in the body, the tibiofemoral joint is made from the two longest bones of the body. Because of the knee joint's complexity and how the medial and lateral femoral condyles function with their corresponding tibial counterparts, it is considered by some to actually be two joints, a medial and lateral joints, while the patellofemoral lies within the common tendon of the quadriceps, which extends above and on the sides of the patella as well as attaching to it. So from the apex of the patella, the patellar ligament is the continuation of the quadriceps tendon and extend to the tibial tuberosity. The menisci provide the knee joint with important properties. Fibrocartilaginous menisci are attached to the tibia to defend the joint socket, improving the joint's congruency, although increased congruency usually leads to less mobility. The menisci provide for both congruency and large range of knee flexion. So each meniscus is attached to the tibia at its anterior and posterior ends or folds. So the menisci have several additional attachment of both ligaments and muscles to this menisci. So in summary, these attachments include: first, the transverse ligament connects the anterior horn of the two menisci together. Second, fibrous bands connect the anterior horns of both menisci to the reticulum of the particular tendon, or the meniscopatellar fibers. Third, deep fibers of the medial collateral ligament attached to the medial meniscus. Fourth, the tendon of the semimembranous muscle sends fibers to the posterior edge of the medial meniscus. So the popliteus muscle sends fiber to the posterior edge of the lateral meniscus. The meniscofemoral ligament extend from the lateral meniscus posteriorly to the inside of the medial condyle near the posterior cruciate ligament. The ligament and the capsule. In addition to the capsule, there are two pairs of ligament, the collateral and cruciate ligament, which are responsible for providing integrity to joint instability. The contralateral ligaments provide stability in the medial lateral direction, whereas the cruciate ligaments provide anterior-posterior stability. So both groups of ligaments are extracapsular and taught in a full knee extension. Collateral ligaments. The attachment of the collateral ligaments on the femoral condyles are offset posteriorly and superiorly to the knee axis for flexion. So this offsetting causes the ligaments to become taut when the knee moves into extension and slack as the knee flexion. The contralateral ligament thus provides stability to terminal rotation of the extended knee and yet permit axial rotation in the flexed knee. Axial rotation is also facilitated by a decrease in the congruency of the joint surfaces when the knee is flexed. So the medial contralateral ligament is a broad, flat ligament that is thickening of the medial joint capsule and attached to the tibia at 2 points. So this attachment allows the ligament to provide joint stability in both flexion and extension. The cruciate ligaments. The anterior and posterior cruciate ligament provide control and stability to the knee throughout the motion of flexion and extension. These ligaments lie in the center of the joint within the femoral intercondylar fossa. It receives their name because of the form of cross when viewed from the side of the front. The cruciate ligaments maintain a relatively constant length throughout the motion of the flexion and extension. These ligaments help to force the sliding motion of the condylar surfaces to occur. Both of the cruciate ligaments arises from the tibia and attach to the distal femur within the knee joint. The anterior cruciate ligament is more oblique, whereas the posterior cruciate ligament follows a more vertical course, which is the anterior cruciate ligament is longer, but the posterior cruciate ligament is thicker and stronger. So each has bundles of fibers that are twisted to form spiral along their course. And this arrangement allows some part of each ligament to maintain taut throughout the knee motion. So the knee ligaments are band of tissue that connect thigh bone to your lower leg bones. They can be classified into two main groups, which is the collateral ligament and cruciate ligament. Sprained and torn knee ligaments are common, especially among athletes. They may be mild, requiring rest, and simple treatment, to severe, requiring surgery. What do the knee ligaments do? Knee ligaments have several important jobs. They absorb shock when the foot strikes a surface, connects the thigh to the lower leg bones, keep the bones in a proper position. It prevents the knee from twisting or collapsing, stabilize the knee, stop the knee from moving in any unsafe or unnatural direction.
So next is the capsule and other inert soft tissue structures ng knees. The largest capsule of the body is the knee's joint capsule. The joint capsule forms a sleeve around the joints, attaching just above the femoral condyles and below the tibial condyles. So there are a few examples of the complex passive and active connections among the menisci, the ligaments, retinacula, bones, muscles, and the capsule. These are the proximal tendon of the popliteus muscles pierces the capsule to attach on the lateral femoral condyle. The semimembranous muscles form part of the oblique popliteal ligaments and gives off fibers to the medial collateral ligament as well as to its large body attachment. So, kagaya ng other joint capsules, yung knee capsule is meron siyang inner synovial layer na isang serous connective tissue na nag-absorb and nagsisecrete ng synovial fluid and is responsible for the mediation of nutrient exchange between blood and joint. And meron din siyang outer fibrous layer, which is consist of white fibrous tissues known as the capsular ligament. So it holds the articulating bones and supports the underlying synovium, which is yung other term for the inner synovial layer, which is binanggit ko kanina. However, these two capsular layers that is mentioned earlier, the synovial and outer fibrous layer, do not adhere to each other like those other capsular layers of other joints. Instead, the posterior aspect of the synovial layer extends more proximally and may also extend distally from the fibrous layer above and below the knee joint. The synovial layer follows the fibrous layers, parang nakabuntot siya sa fibrous layer around the medial and lateral aspect of the knee, pero naghihiwalay na yung synovial layer sa fibrous layer at the superior of patella and expands to form a large pouch proximal to the patella under the quadricep muscles. So this area is called the suprapatellar pouch. Kung yung knee joint natin is injured and nakaka-experience ng extensive swelling, itong pouch na to, the suprapatellar pouch, is magiging enlarged siya or magiging malaki siya and magiging noticeable siya extending for about 5 centimeters proximal to the patella. So in addition to the collateral and cruciate ligaments, other ligaments, particularly in the posterior knee, lend support to the joint capsule. These primary and most consistently present ligament include the arcuate ligament complex and the popliteofibular ligament. These are the expansion of posterior capsule that adds support during torsional stress or yung kapag nakaka-experience yung body natin ng sudden twist formed by shear applied to the posterior capsule. So next is the kinematics of tibiofemoral joint. So kinematics is the science of describing motion of objects. So, pwede natin siyang i-describe using words, diagrams, graphs, mathematical equation, numerical data, and iba pa. So, kinematics of tibiofemoral joint. So, mayroon daw 2 degrees of freedom ang ating knees. Flexion, extension, and axial rotation. So, natakal na natin yung normal range of motion ng knee flexion, which is 135 degrees. Pero kapag yung hip is nag-extend, the range of motion of knee flexion decreases kasi may limitation by the 2-joint rectus femoris muscle, which has its proximal attachment to the anterior inferior spine of the ilium. Tapos, yung normal range of motion naman ng knee extension is 10. Pero kapag nakaya pa niya or like nag-hyperextend siya, ang pinaka like normal na nag-exceed lang is 15 degrees. So, the axis for flexion and extension. So, normally, like scientifically speaking, the axis of motion is located a few centimeters above the joint line, passing medially, laterally through the femoral condyles. Because the condyles of the femur are so much larger than those of the tibia, the femoral condyles not only roll over the tibial condyles when the knees move from extension into flexion in weight bearing, but they must also glide so they don't roll off the tibia. Since the femur glides as it moves in flexion extension, the center of axis of motion changes as the range of motion changes. So, dahil mas malaki daw yung condyles ng femur kaysa sa condyles ng tibial, yung femoral condyles is habang kapag ginawa natin yung knee extension to flexion, yung femoral condyles is hindi lang siya magro-roll, kailangan din niya mag-glide para hindi siya maalis or like maalis nga sa pwesto ng tibial condyle. So, for example, yung nakalagay dito, when you flex your knees to sit down, your femur rolls backward. However, the surface of the tibia is used up during this rolling maneuver before the knee is done flexing. So, the femur must glide forward to a new location on the tibia so it can continue rolling back to allow your knees to flex sufficiently to allow you to sit on the chair. So, kapag uupo tayo, mag-flex yung knees natin. Ang mangyayari doon ay yung femur is magro-roll backwards. Tapos, since maliit yung condyle ng tibia, or mas maliit yung surface niya. So, before matapos yung rolling motion na ginagawa ng femur, is nagamit na lahat ng space ng sa tibia, causing na yung femur natin is mag-glide forward para may space na ma-create. Tapos, pwede na tayong makaupo using our sufficient flexion for sitting. So, pag tatayo naman, so yung knees natin is nagper-perform ng reverse maneuver during closed chain activities. So, yung closed chain activities is mga movement na parang yung distal portion or like yung distal part is nagsistay lang sa place niya. So, ang mangyayari is magpo-forward roll yung femur, since naka-flexion na tayo, magpo-forward roll yung femur sa tibia, and habang nagpo-forward roll siya is mag-glide siya palikod. So, mag-glide siya palikod as the femoral condyles run out of space on the tibia but need to continue to roll forward until you are fully standing. So, ang tawag daw dito sa continual change in center axis of rotation is the instantaneous center of rotation, or the ICR. The relationship between the glide and the direction of rolls during the flexion and extension changes when the tibia moves and the femur is stabilized because the surface that is moving is different. The changes that occurs in knee joint center of rotation is one of the reasons it has been difficult to design either an artificial knee that is closely resemble to a normal knee or an external device that are applied to the joint. Because of the shifting axis of motions of the human knee, the problems occur when the device with mechanical hinge joints such as isokinetic dynamometer or the knee, ankle, foot, long leg orthosis or above knee prosthesis are applied to the knees. Kapag yung knees natin is nag-move from extension to flexion, the anatomical axis of the knees moves about 2 centimeters, while the mechanical axis of the attached device is remained fixed. Kaya yung arms ng mechanical device cannot remain parallel to the thigh and leg, and motions or pressure between the mechanical and anatomical parts that will occur. So, kailangan kapag maglalagay ng mechanical device, kailangan careful alignment para maiwasan yung discomfort at mga gasgas. So, kapag naman na misalign yung orthotic knee joint is maaari siyang magkaroon ng pressure sa device cuff on the extremity kapag knee flexion, kapag gaping naman kapag knee extension. Next is the axial rotation. So, axial rotation occurs in the transverse plane when the knee is flexed. When the knee is fully extended, the medial and lateral collateral ligaments are relatively tense, contributing to the stability of the joint, preventing rotation. These ligaments slackens when the joint flexes. This is one of the reasons why a considerable amount of transverse rotation may take place in flexed position. So, kapag yung knees natin is fully extended, yung medial and lateral collateral ligaments natin is tense, kaya hindi siya makakapag-rotate. Kapag naman knee flexion tayo, yung ligaments na yon is parang imbis na magte-tense, mag-i-slack siya, parang luluwag siya. Kaya possible na yung transverse rotation may take place in flexed position. And so, dito sa picture, makikita natin na kapag sa lateral view, kapag naka-extend yung knees natin, makikita natin yung lateral collateral ligament is parang stretched siya. Tapos, kapag naka-flex naman is naka-slacken. Tapos, sa medial lateral view naman, naka-stretch din yung medial collateral ligament kapag naka-extend. Tapos, yung kapag naka-flex naman is nag-i-slacken siya. During knee flexion, more slack is produced in lateral than in medial collateral ligament. Therefore, the movement between the femoral and tibial condyles is more extensive laterally than medially. Transverse rotation takes place about the longitudinal axis located medial to the intercondylar ridge of the tibia, so that roughly it may be stated that the lateral condyle rotates around the medial one. So, yung lateral rotation was approximately twice as large as medial rotation. So, axial rotation decreases as the angle of knee flexion becomes smaller and cannot be performed as the knees approaches extension. So, ang major functional importance of this motion, the axial rotation, is in closed chain motion, in which the femur rotates on the fixed tibia as in turning from kneeling, sitting, or squatting position, and in sudden changes in direction when running. So, ang normal end feel nito for passive medial and lateral rotation of the knee are firm. Next is the terminal rotation of the knee. So, nangyayari yung terminal rotation of the knee kapag mag-knee extension tayo, tapos sa last 20 degrees ng knee extension is magla-laterally rotate tayo for about 20 degrees on the fixed femur. So, ang tawag dito is terminal rotation of the knee or the screw home mechanism. So, the medial tibial rotation occurs with knee flexion and the lateral tibial rotation occurs with knee extension in the open chain. Some observation of the femoral abduction and adduction was also noted, but the occurrence of this additional coupling motion of this movement with flexion extension was inconsistent. In closed chain motion such as rising from chair, the terminal rotation occurs as medial rotation of the femur on the fixed tibia, whereas the lateral femoral rotation occurs when returning to the chair as the knee moves from extension to flexion. So, the screw home mechanism or yung terminal rotation of the knee provides mechanical stability since it locks the knee. So, therefore, in this position, the knee is able to withstand forces occurring in the sagittal plane. The locked knee also permits human to stand erect without the need of quadricep muscle contraction, and it allows the extended knee to withstand anterior-posterior forces with reduced muscle force. So next is the atriokinematics of the tibiofemoral joints. So atriokinematics refers to the movement of joint surfaces. So, ang closed tuck position ng knee is kapag nasa full extension siya. So, kapag nasa full extension tayo, yung terminal rotation is nagpo-produce ng tightening of ligamentous and capsular structure to provide strong stabilization of joints. So, nasa most congruent position yung tibiofemoral joint kapag nasa full extension siya. Tapos, kapag sa least congruent position naman is kapag naka-flex position or naka-rest yung knees natin. The concave tibial surface slides or glides in the same direction as the roll or joint motion when the tibia moves on the femur during the open kinetic chain activity. Therefore, when the tibia rolls forward on the femur into extension, it also glides forward. Likewise, when the tibia rolls backward as the knee moves into flexion, the tibia glides posteriorly. So, into knee extension, kapag yung tibia natin is nag-roll forward sa femur, mag-glide forward siya. Tapos, kapag nag-roll backward naman siya, yung glide niya is pa-posteriorly. During closed chained motion, then, as the knee moves into extension, the roll of the femur on the tibia or joint motion is forward while the glide is posterior. The reverse direction of movements of the roll and glide occurs when the weight-bearing knees moves into flexion. The roll of the femur is posterior and the glide is anterior. So, sa closed chain motion naman, kapag yung knees is mag-extension, yung roll ng femur sa tibia is pa-forward, while yung glide is palikod. So, the closed back position of the knee is full extension. So, kapag full extension, yung knees natin, yung terminal rotation is nagpo-produce ng tightening of ligamentous and capsular structure to provide strong stabilization of joint. So, kapag nasa full extension tayo, yung tibiofemoral joint natin is nasa most congruent position. Tapos, kapag flex position naman, yung tibiofemoral joint natin is nasa least congruent siya yung position niya. So, the concave tibial surface slides or glides in the same direction as the roll joint or joint motion when the tibia moves on the femur during open kinetic chain activity. When the tibia rolls forward on the femur extension. So, next joint is the patellofemoral joint. So, siya yung joint na nagko-connect sa patella and femur. The patella lies within the common tendon of quadriceps, which extends above and on the sides of patella as well as attaching to it. from the apex of the patella. The patellar ligament is the continuation of the quadriceps tendons and extends to the tibial tuberosity. On the sides of the patella, tendinous fibers spreads out to form the medial and lateral retinacula, which attach to the condyles of the tibia. It articulates with the anterior and the distal saddle-shaped surfaces of the femoral condyles or the trochlear surface. So the patella is a sesamoid bone, which is bone embedded within a tendon or a muscle. The patella is protected by both active and passive constraint. Kahit walang masyadong stable joint na naka-attach sa patella, it is protected by both active and passive constraint. Kapag naka-full extension yung knee natin, yung stability ng patella relies primarily on the soft tissue which surrounds it. Yung extensor, quadricep mechanism actively stabilizes the patella on all sides and guides the motion between the patella and the femur. From 30 degrees to 0 degrees, the primary responsibility of the vastus medialis oblique or the VMO muscle is to serve as a dynamic stabilizer of the patella. So, the patella also receives additional stability from its surrounding structure. So, distally, the patella is anchored to the tuberosity of the tibia by the strong patellar ligament connecting the patella to the tibial tuberosity. Yung dense, fibrous medial and lateral retinacula as well as muscle anchor the patella on each side also aid in stability. So laterally naman, the patella is passively stabilized by superficial and deep retinacula, the iliotibial band, and the vastus lateralis muscle. So, sa superior stability occurs actively from attachment from the rectus femoris and the vastus intermedius to the base of the patella, whereas inferior stability is provided to the patella by the patellar ligaments. Pag yung knees natin is nagfe-flex, yung lateral structure ng patella is nagmo-move posteriorly and nagre-create siya ng lateral and tilting forces on the patella. Therefore, yung patella is affected by both static and dynamic forces. In essence, the minimal congruency between the posterior patella and the anterior femoral condyles forces the patella rely on the soft tissues for its stability. Kinematics of the patellofemoral joint. So, yung patellofemoral joint is connected talaga sa tibiofemoral joint. Hindi lang sa anatomy, pero sa function din. Yung pag gumalaw yung tibiofemoral joint, gagalaw din yung patellofemoral joint. Kapag may restriction, yung mobility ng isang joint is maapektuhan din ng isa. Kapag yung may weakness and muscle controlling, maapektuhan maapektuhan nila yung isa't isa. Kaya yung essentially, both injury and health of one joint directly impacts the other joint. So, una is yung patellofemoral contact. As the knee moves from extension into flexion, the patella and femur move relative to one another, which moves depends on whether it is an open or closed chain motion. So, kapag yung knees natin is nag-move from extension to flexion, the patella and the femur move relatively to one another, which depends on whether it is an open or closed chain motion. So, sa open chain activities, kapag yung tibia yung nagalaw, yung distal part, and then yung femur yung stationary or yung proximal natin yung stationary, the patella moves over the femoral condyles. Kapag naman closed chain activities, the femoral condyles glides along the patellar surface. So, kapag naman yung knees natin is fully extended, yung patella sits at the proximal end of the intercondylar groove. Kapag yung quadriceps muscle natin is relaxed, ang contact lang na magagawa ng posterior patella ay sa inferior pole on the suprapatellar fat pad. Tapos, kapag yung knee natin is nag-move into flexion, yung patella natin ay magko-contact sa femur at about 25 degree of knee flexion. The lower margin of the patella makes the initial contact with the intercondylar groove superior aspect at this time. So, makikita natin sa picture sa gilid, as the knee continues to flex, yung patella is nag-move inferiorly and progressively increases the patellofemoral contact area until about at 90 degrees of knee flexion. So dahil dito, a maximum contact area between the patella and the femur occurs. Kapag yung knees naman natin is nag-flex up to 115 degrees, the patella makes contact with the medial and lateral femoral condyles at the point at which the intercondylar sulcus is present. So the contact surface area between two bones decreases. By the time the knee flexes to 135 degrees, the odd facets and the lateral facet of posterior patella are the only areas in contact with the femoral condyles. So next is the patellofemoral static and dynamic alignment. So when the tibiofemoral joint is in full extension, the patella rests at the proximal aspect of the intercondylar groove. So yung patella, yung position niya and stabilization is mostly maintained because of the surrounding soft tissues. Yung health and condition ng soft tissues is important to the patella's alignment. So both inert, the connective tissues, and the active tissues, the muscles, impact the patellar alignment. With the knees relaxed in full extension, the patella lies in the proximal intercondylar groove. When the knee flexes and extends, the patella moves in several directions: flexion extension, medial lateral tilt, medial lateral shift, and medial lateral rotation. Kapag yung knees natin is naka-full extension tapos relax, yung patella natin is nagre-rest lang sa proximal intercondylar groove. So, pag yung knees naman natin is nag-flex and extend, syempre, gagalaw din yung patella natin. So, gagalaw siya sa flexion extension, medial lateral tilt, medial lateral shift, and medial lateral rotation. So, dun sa mga movement na nabanggit, ang greatest excursion na magagawa ng patella is through the flexion and extension. Kasi nagmo-move siya proximally and distally sa intercondylar groove. The patella travels from full knee extension to full flexion, a distance of 5 cm to 7 cm. So, yung apex nga ng patella lies near the tibiofemoral joint margin when the knee is fully extended. So, kapag yung patella is naglalay more distally on the femur, it is patella baja. If it lies more proximally, it is patella alta. Either pathological alignment will cause the anterior knee pain and abnormal patellar tracking during the knee flexion and extension. So, imbalances such as tightness of the iliotibial band or the weakness of the BMO causes the patella to track more laterally with muscle contraction of the quadriceps during knee movement and may lead to changes in joint contact areas and pressure with the resulting pain and dysfunction. So next is the atriokinematics of the patellofemoral joint. The posterior patellar surface is concave and moves on the convex of femoral surface. So therefore, the patellofemoral joint abides the concave on convex principle. So, ang resting position ng patellofemoral joint is kapag naka-full flexion si knees and kapag close back position naman is naka-flexion si knees. So, as the knee flexes and extends, the patella glides within the intercondylar groove. As the knee moves into flexion, the patella glides inferiorly, and as the knees extends, the patella glides superiorly. Kapag yung knees natin is mag-move sa flexion, yung patella natin is mag-glide inferiorly. Kapag naman yung knees natin is mag-extend, yung patella is mag-glide superiorly. So, sa patellar rotation, nag-move yung patella in medial lateral shifting and medial lateral tilting, and nag-occur siya during knee flexion and extension. So, with the quadriceps resting in full knee extension, the patella is unrestricted as it sits in the proximal intercondylar groove. It may be passively mobilized medially, laterally, superiorly, inferiorly, and rotated medially and laterally a few centimeters. So, next is Q angle. So, the Q angle, by definition, is formed between a line representing the resultant line of force of the quadriceps, connecting a point near the axis to the midpoint of the patella, and a line from the center of the patella to the center of the tibial tubercle. So, the sizes of the angle is variable for both sexes. So, study places that the range of values for men is about 10 degrees to 14 degrees, na mas malaki yung sa women, which is nagre-range siya sa about 15 degrees to less than 20 degrees. So, may mga nag-speculate na isa daw sa mga reasons kung bakit pag iba yung angle ng men and women is mas malaki daw yung pelvis ng women, which causes greater angle between the femur and tibia, but this reason has been disproven. Meron din naman mga indication na yung mga smaller angles in men may be results of either differences in strength or differences in height. Although there may be differences between men and women, this Q angle occurs in both groups as the femoral shaft adducts so the tibia is able to transmit the body's weight perpendicularly to the foot and ground. Kaya pag natayo tayo ng isang paa lang, the forces is directed towards the medial side of the knee. Kapag naman excessive yung Q angle natin, ang tawag doon is gynovalgum or knock knee. Yung gynovalgum is a condition in which the knees angles is in and touch each other when the legs are straightened.
Muscles. Many of the muscles that cross the knee joint also cross either the hip or the ankle. Therefore, how well they perform at the knee is dependent upon their other joints' position. Recall these three factors. Number one is active insufficiency occurs when a multi-joint muscle shortens but is unable to shorten sufficiently to allow full joint motion at all the joint it crosses. Number two, passive insufficiency occurs when a multi-joint muscle is unable to stretch sufficiently to allow both joint it crosses to fully shorten. And last, optimal sufficiency occurs when opposing muscle at one end where a multi-joint muscle attaches position that joint to allow optimal function of the multi-joint muscle. Dito sinasabi na madalas gamitin itong tatlong principles na to during the knee motions. We will identify the muscle surrounding at the knee and then gagamitin natin itong tatlo na to apply to knee function. Yan, kagaya na lamang ng knee extensors. Knee extensors, the quadriceps femoris muscle group extends the knee and includes four muscles. Ano yun? We have the rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. This four muscle forms a single, strong distal attachment to the patella, capsule of the knee, and an anterior proximal surface of the tibia. So yun, yung apat na muscle group na yan is ma-notice mo siya, syempre, and observe sa quads mo or sa thigh mo. And separate unit sila, syempre, dahil group sila, hindi sila isang buong muscle, tigi-tigi sila. Whereas in other subjects, the boundaries of the muscle are less distinct. Katulad na lang ng vastus intermedius. Sobrang lalim na niya, hindi mo na siya ma-observe or makakapaman lang sa thigh mo. Yun, cannot be observed from the surface. While the rectus femoris occupies the middle of the thigh, kung saan nasa yung gitna ng thigh natin, dun mo makakapa or nalaki siya, magiging noticeable din siya after mong mag-exercise ng mag-leg exercise. Eventually, lalaki yung thigh mo. And it is the only quadriceps muscle which also moves the hip joint. And last, the vastus lateralis is the largest of the four quadriceps. Kung saan ito talaga yung madalas kong mapansin personally kapag nag-exercise or nag-gym, lalo na kapag nag-squat. Yan. Pag finlex natin in-extend natin yung knee natin, doon mo talagang manonotice si vastus lateralis, kung saan located siya syempre sa lateral side of the rectus femoris. Sobrang laki niya, uumbok talaga yung muscle na yon. Yan. Mapapansin yun, pwede niyong kapain sa inyo. And lastly pala, the vastus medialis lies in a position, syempre, medialis is medial to the rectus femoris.
The vastus medialis has two different fibers direction and therefore two different functions. So next we have knee flexors. A number of muscles pass posterior to the flexion extension axis of the knee, contributing to a variable extent of knee flexion. The primary muscles are the hamstring, we have biceps femoris, semitendinosus, and semimembranosus. But other muscles also contribute to knee flexion. These muscles include the plantaris, popliteus, gracilis, and sartorius. So, saan ba located si bicep femoris? Si bicep femoris ay nasa posterior thigh and is also known as the lateral hamstring. The semitendinosus is on the medial hamstrings with its muscular portion positioned medial to that of the long head of the bicep in the posterior thigh. Although the semimembranosus has the largest cross-section of the hamstring, it is not easily palpated katulad ng mga individual muscle kasi most of it daw is covered by the semitendinosus and proximally by the abductor magnus. Together with this muscle, the semimembranosus makes up the large muscular mass of the medial and posterior thigh. Last, the tibial rotators. The muscles that act as medial rotators include the semitendinosus, semimembranosus, popliteus, gracilis, and sartorius. The tibial lateral rotator is the bicep femoris, which is possibly aided by the tensor fascia lata. The bicep femoris is a strong lateral rotator. Contraction of the bicep femoris may be isolated from the medial hamstrings by placing the subject prone with the knee flexed slightly beyond 90 degrees. Next topic is function of muscles of the knee. The two main muscle groups of the knee include the knee extensors and the knee flexors. Although the tibia also rotates on the femur, this rotation occurs from contraction of the knee flexors since many of the muscle crossing the knee also cross another joint. How they work at the knee during functional activities is dependent upon the position of the other joint this muscle cross. Since there are so many two-joint muscles operating at the knee, they also impact the responsibilities of the single-joint knee muscle during functional activities. This section investigates this interaction of muscle function. So, ano-ano ba yun? We have knee extensor pa rin. The quadriceps femoris is a large muscle group that is responsible for stabilizing, accelerating, and decelerating in the knee during functional activities. For example, it will provide an isometric muscle contraction to stabilize the knee during a downhill sky run, or will produce a sudden concentric activity during a jump up, or it will decelerate knee flexion when the body lands from a jump. Yan, si knee extensors is very essential for our daily activities like um, pagpanik pagpanik akyat pagpanik baba sa stairs, climbing, getting up from the chair, walking, and even sa mga sports like running, track and field, cycling, and other stuff like other sports, basketballs that requires jumps. So next natin is the knee flexors. There are several muscles that serves as flexors in the posterior knee. This muscle, however, have additional roles including hamstrings and popliteus. Ano ba ang hamstring? This is the muscle are primary hip extensors and contract strongly to stabilize the pelvis during prone trunk extension. The hamstring also serves to stabilize the knee by restricting an anterior glide of the tibia on the femur. Kasi open chain motions daw siya of knee flexion and rotation that require a little muscle force to execute. On the other hand, great forces are required of this muscle as they act on the knee in closed chain motion or on the other joint they cross. Ano bang mga activities yung nagagawa natin ng mag-knee flex? 'Di ba? Nandiyan ang kneeling or squatting position such as gardening, mining or playing football, welding, doing chores, requires strong force from this muscle to initiate and control hip and knee motion, including rotation on the fixed tibia in response to necessary twist of the trunk and upper extremities. Thus, injuries of the knee flexors, such as a hamstring strain, are more commonly due to their actions as rotators or as decelerators of limb motion than a flexor of the knee. Next is popliteus. Dito, sabi sa popliteus is a muscle is deeply set in the calf. So, yun, hindi natin siya makakapa or hindi natin siya makikita. Kasi, lalo na nasa posterior siya ng ano natin dito sa may likod ng tuhod. So, hindi talaga natin siya ganun mapapansin. And difficult to palpate nga or study, sabi dito. And although it is a small muscle, it has important functions. The arrangement of its distal insertion on the tibia gives the muscle a somewhat triangular shape and its insertion into the medial collateral ligament. So, yun. Proceed na tayo sa one joint and two joint muscles acting at the knee. Only 5 of the muscles that act on the knee are one joint muscles. The 3 vasti, the popliteus, and the short head of the bicep femoris. The remaining muscles cross both the hip and knee, the rectus femoris, sartorius, gracilis, semitendinosus, semimembranosus, long head of the bicep femoris, and the iliotibial tract of the tensor fascia lata, or the knee and ankle, or the gastro. There are maybe important reasons why the knee has primarily two joint muscles. One joint muscle usually function synergistically with its two joint against, for example, the vasty portions of the quadriceps are active when the rectus femoris also works to extend the knee. However, when the single joint muscle group's movement arm shortens as knee extension continues, uh, it, it forces output is reduced. But as the rectus femoris continues to work at the knee, additional force may be added at the knee by placing the hip in more extension, thereby lengthening the muscle as its proximal insertion. Yan. One joint muscle daw usually nagpo-produce siya ng motion na in only one plane. For example, the vastus intermedius produces knee extension. On the other hand, biarticular muscle also produce a transverse component. One joint or monoarticular muscle are usually used to produce force, whereas the biarticular, the two joint muscle, determine direction of movement. As we discussed in earlier chapters, yan, our muscular system is one of the redundancy. There are many more muscle available to perform an action than is required for movement. This redundancy, however, is important since it allows the body to perform functional activities efficiently. Oh, yan. Since there are so many two joint muscle crossing the knee, it is important to identify how each muscle performs relative to the other joint it crosses as it performs its function as the knee. The action of the two joint muscle is considered in the following movement combinations. We have knee flexion combined with hip extension. Ano ba yun? I-flex natin yung knee and mag-hip extension tayo. Pwede nyo pong gawin siya ngayon kung gusto nyo po. If the subject is lying prone or nakadapa or standing erect and flexes the knee while extending the hip, the hamstring muscles, mapapansin nyo, mararamdaman nyo, must shorten over the both joints simultaneously, and difficulty is experienced in completing knee flexion. So, yun. Kasi kumbaga umiikli na yung natin, yung hamstring natin, hindi natin ma-complete yung knee flexion. Next is knee extension combined with hip flexion. So, yun, pwede nyo po ulit gawin. I-extend lang natin yung knee combined with hip flexion. An active straight leg raise may be performed in a supine, nakahiga, or standing position. A straight leg raise includes moving the hip into flexion while maintaining an extended knee. As the hip moves through its motion, the individual reaches a point na kumbagay hindi na niya kaya, hanggang dun lang. Yun lang yung limited motion niya. Cannot continue. Yan. Or if it does, the knee flexes. Kapag isipin natin na nakahiga si patient, tayo sa kanya ng SLR, just straight leg raise. Hindi naman lahat ng tao is kayang mag-flex ng pagpalagay na 90 degree. Diba? Mamaya, sobrang sakit na pala sa patient sa 30 degree o 40 degree. Doon na limited na range of motion ni patient. So, ang gagawin natin is try to flex her knee para tingnan natin kung kaya pa niyang ma-increase yung hip flexion. Kasi usually, mag-i-increase talaga yun. So, yun. Next is knee flexion combined with hip flexion. So, parehas flexion. Pwede nyo po ulit gawin, i-flex ang knee combined with hip flexion. During hip flexion motion, the hip flexors and the hamstrings act synergistically to provide a functionally useful movement, whereas in other movement combination, these two muscle groups may act as antagonists. We use this combination to our advantage during walking, running, and hopping activities. Knee extension combined with hip extension. Extend si knee and mag-extend din ng hip. Another common combination of hip and knee motions and torque production during functional activities is knee extension with hip extension, of course. This is a most useful combination that occurs in activities such as rising from the sitting position, climbing stairs, running, and jumping to propel the body forward or upward. This positioning of knee extension, usually by contraction of the quadriceps, allows the hamstring to elongate over the knee and act as hip extensors. So, yan. Di ba makikita natin siya sa climbing stairs? Yan. Running and jumping. Sa climbing stairs, pag akyat natin, di ba, once na umapak na yung paa natin sa surface ng stairs, syempre, aangat tayo. So, lahat mag-extend dun sa isang leg na yon, diba? So, other leg, ganun, and so on and so forth. And sunod is running. Syempre, once na tumatakbo tayo, yung may iwan na leg syempre, sisipa tayo ng malakas na, kukuha tayo ng puwersa, ng buwelo. So, lahat naka-extend yung hip and knee natin doon. Same as jumping, yung pagtalon. Naka-extend, syempre, mag-extend lahat yung leg natin. So, yun. Dito naman, knee flexion combined with ankle plantar flexion. The gastro is capable of performing motions of knee flexion and ankle plantar flexion simultaneously, but if full range and both joint is attempted, the muscle has to shorten a long distance and tension falls rapidly. As with other two joint muscle, it quickly faces active insufficiency and is unable to fully flex both joints simultaneously. Therefore, as in simultaneously knee extension with hip flexion or knee flexion with hip extension is not a very useful movement. Last, we have knee extension combined with ankle plantar flexion. The quadricep extends the knee, whereas the gastro and the soleus plantar flex the ankle. As the quadricep extends the knee, the gastro becomes elongate over the knee, an optimal condition result for plantar flexion of the ankle. This functional combination is commonly seen, for example, in rising on tiptoes, running and jumping. The synergistic relationship between muscle provides for optimal sufficiency. So next we have joint forces. Even in normal activity, the articulating surfaces of the knee sustain forces that far exceed body weight and are thus subject to microtrauma and its subsequent generative result. Tibiofemoral joint forces. The body weight vector passes between the knee when standing on both feet, and each tibial plateau has a compressive force of 45% of body weight, 68 pounds in a 150-pound person. In unilateral stance, however, the compressive force increases to about twice the body weight. In standing, this compressive force is equally distributed over the weight-bearing surfaces of the tibia. The knee supports the weight of the thigh and the opposite lower extremity during single limb stance. This weight acts through a center of gravity that is slightly higher than S2 and projects to the base of support when the body is in a single limb stand position. This line of gravity passes on the medial side of the knee, causing a varus thrust, as you can see in this figure. So, si tibiofemoral joint daw is nagpo-function siya with a synovial joint, mostly as a hinge plus a small amount of rotation. Hindi natin siya basta sabihin na nag-hinge lang. Meron pa rin small amount of rotation pag nag-flex tayo. Anong mga articulation between the we have two articulation between the two femoral condyles or the convex and tibial condyles or the concave. The femur, yung femur condyle niya is convex. Ang tibia condyle naman is concave. The articular surface of the femur are larger than the surface of the tibia, causing sliding of femur to maintain contact with the tibia. Kaya sinabing na tibiofemoral is between the tibio and femoral joint. Kung bakit din sinabi na patellofemoral is between the patello and femur joint, which is i-discuss natin after this. So, during normal walking daw, tibiofemoral compression forces reach almost 4 times body weight, with the majority of that force, or 60%, borne by the medial compartment. It may be for this reason that the medial tibial condyle has about 3 times as much articular cartilage as its lateral counterpart. Dynamic forces occur at both the hip and knee in unilateral stance through the attachment of the gluteus maximus and the tensor fasciae lata muscles. Tension of the IT band can be palpated on the lateral thigh of the tibia when a person stands on one leg. As the knee moves from extension to flexion, shear stresses are applied to the tibiofemoral joint, especially in moving from full extension to about 90 degrees of flexion. The menisci assist in both absorbing some of the forces applied to the knee and dissipating the forces over a larger area. Abnormalities that alter the torch of the body weight or the iliotibial band result in movement of the receiving excessive psychological pressure over many years may develop pain, destruction of articular cartilage, and worst, osteoarthritis. An example of biomechanical causes in the development of the knee joint pathology is seen in obesity. So next, we have the patellofemoral joint forces. The patella may be thought of as a pulley for the quadriceps since it does change the angle of force of the quads. The change in the angle of pull created by the patella does not seem significant, but the actual calculation tell a different story throughout the range of motion. The knee loses 15% to 30% strength following a patelloctomy. In other words, without a patella, the quadricep must work 15% to 30% more to exert the same amount of force it does when the patella is intact. Because the patella attaches to both the quadricep tendon and the patellar ligament, it becomes tethered when the quadricep contracts. These two forces pulling on the patella from opposite directions create a compression of the patella against the femur. As you can see in the figure, with the knee extended, the resultant force is small because the forces of the tendon and ligament are almost on a straight line. And so see joint of between patello and femur joint. The primary functional role of the patella is knee extension. The patella increases the inverge a mechanical advantage that the quadricep tendons can exert on the femur by increasing the angle at which it pulls on the tibia. Patella is stabilized by the insertion of the horizontal fibers of vastus medialis. And when doing a squat, the joint reaction force increases to 7 to 8 times body weight. It is no wonder what patient with patellofemoral pain syndrome report that their pain increases when going up or downstairs and kneeling or squatting activities. The stress the patellofemoral joint encounters occurs from the force that compresses the patella into the femur. This is also known as the patellofemoral joint reaction force. As with the tibiofemoral joint, this joint reaction force also changes depending on whether the knee is moving in open or closed chain functions. Patellofemoral compressive force in open kinetic chain activities is greatest at 0 degree and decreases as the knee moves to 90 degrees. In a closed kinetic chain motion, patellofemoral stress is greatest at 90 degrees and decreases as the knee moves into full extension. Next is torque of muscle acting at the knee. Muscle forces applied to the knee create arcs of motion. The force created is torque. Torque forces applied to the knee are substantial. Quadricep femoris torque. The quadricep is able to maintain about 90% of its maximum strength from 80 to 30 degrees of flexion. Quadricep strength is optimized through utilization of the combined strength principle of psychological length and moment arm length. With the knee at 80 degrees where the quadricep provides high strength levels, there is a favorable length tension relationship of the vasti muscles combined with these factors, the change occurring in the patella's moment arm length as the knee continues through its range of motion allows for better quadricep strength output as the knee moves into in extension. Quadricep femoris torque is a knee is fully flexed. The patella lies in an intercondylar groove and close to the axis of motion. As the rectus femoris as two joint muscles provides for maintained strength levels, as the knee extends, the patella moves out the groove to reach maximum lever arm distance at 45 degree of flexion, measured mean patellar lever arm distance of 3.8 cm to 90 degrees of flexion and 4.9 cm at 45 degrees. The lever arm distance then decreased to 4.4 cm at full extension. We have already discussed the advantage that occurs to the rectus femoris if the hip extends as the knee extends to allow the muscle to maintain a relatively unchanging length. As the knee moves near extension, the quad's ability to produce force is significantly diminished, and individual who is unable to achieve full active knee extension but has full passive motion into extension has an extensor lag. Full knee extension is very important to regain following injury or the presence of restricting structures. In the case of an extensor lag, if pain is caused, treatment must be instituted to relieve the pain. Pero if incomplete naman daw ang extension, imposible siyang actively or passively, then there may be either maging joint restriction or soft tissues restriction causing the problem. So hindi siya extensor lag. Joint restriction may occur from tightness within the joint capsule or a bony block preventing movement. Soft tissues restriction are usually caused a scarring around the near a joint by an inflexible muscle or by edema. So yan. Next is knee flexor muscle torch. The maximum isometric torch measurement of the hamstring muscle shows that the greatest torch occurs when the muscles are elongated at both the hip and knee, hip flexion and knee extension, and that the lowest torch occurs when the muscle contract. It is shortened position of hip extension and knee flexion. Reduction in strength in spite of changes occurring in the hamstring. Moment arm may lend additional argument to the idea that the patella plays an important role in maintaining high strength output of the quadricep throughout a significant range of motion. So, functionally daw, the need for great torch is knee extended during hip flexing position occurs in closed chain motion when the hamstring muscle are the primary muscle group used to lower and raise the weight of the HAT when a person is reaching over to touch the floor or bending forward in the sitting position. Last, we have second to the last, we have hamstrings. Last, hamstring to quadricep torch ratio. The peak torch for the quadricep muscles are greater than those of the knee flexors. This is not unexpected because the knee extensors have over twice the cross-sectional area of the knee flexors, and the knee extensors have a longer moment arm distance than the flexors. Strength imbalance between this muscle group has been suggested as a basis for injuries such as hamstring strains, normative values for hamstring quadriceps ratios, the peak torch of hamstring divided by peak torch of quadriceps are 0.60 to 0.69 at 60 degrees per second, increasing to 0.85 to 0.95 at 300 degrees per second. Not corrected but for gravity. However, when force output is corrected for gravity, the ratio is lower. That will be 0.45 to 0.55 and does not change with speed. And lastly, we have the interaction of muscles and ligaments in functions. The frequency of progressive instability and disability after ACL injury and reconstruction has directed attention to investigation of sensory functions of ligaments and joint tissues in human subjects. First, we have the sensory innervation and reflexes. Ligament capsules and other soft tissues of the knee are richly innervated with sensory nerve fibers and receptors. Mechanoreceptors have been found in human cruciate and collateral ligaments, the capsules and synovial lining, and on the outer edges of the menisci. Reflexes from joint mechanoreceptors to muscles have been demonstrated in human subjects, including facilitation of the hamstring and inhibition of the quadricep with loading of the ACL. So, swelling in the joint capsule has long been known to produce inhibition of the quadricep and a sudden collapse of the knee. This inhibition has been considered to be caused by deformation of the mechanoreceptors in the ligaments and capsules. And sabi dito is when ACL injuries occurs, there is a decrease in individuals' proprioceptive abilities. When a joint ligament is injured, there is a delay in the time to respond to perturbations. These studies indicate that the ACL deficient knee is unable to react to stresses within a safe time response. Since it takes an individual longer to respond to stresses applied to the joint, the knee is at increased risk of injury. So we have next is the static and dynamic connection. These interconnections include the numerous attachment to the menisci, the reinforcement of the capsule by ligaments and retinaculum, and the extensive soft tissue attachment of the semimembranosus and the iliotibial band, and the penetration of the capsule by the popliteus muscle. And lastly, muscle protection of ligaments. Sometimes muscle are used naturally to protect ligaments, and sometimes the situation is pathological. An example of the naturally occurring use to muscle to reduce ligament stress is seen in walking. At the end of the swing pace, the hamstring contract to decelerate the swinging limb and reduce stress on the cruciate ligament. Yan. In addition lang na remember it or take note, the popliteus is not only served to initiate unlocking the knee from full extension, but it is important active stabilizer of the knee as well. Instance, the soleus, one joint muscle that crosses the ankle, also lends secondary assistance ng ating tuhod. So, yun po. Sabi is when the soleus contracts during weight bearing, the anchored foot remains in place, but the tibia moves posteriorly, causing the knee to move into extension. The gastro then plays an important role in controlling the amount of knee extension and preventing hyperextension.